Now, it's interesting to be able to ask to introduce people who need no introduction. So I'm not going to take much more time, but just to say we are delighted that our honorees for tonight's dinner, Cliff and Joyce Penner, agreed to share some of the wisdom that has made them such an impactful part of our Fuller community and impactful in the church, share that with us today. So with no further ado, please welcome Cliff and Joyce Penner.
It's very interesting for us to be back here 50 years later, because it was 50 years ago that we gave our first series of talks on sexuality to the wives of seminary students. That was in the day when men went to seminary, and
they offered an evening class for the wives, non-credit. So we got asked to teach this course for 10 weeks, 2 hours every Wednesday evening. We had never been experts on sex. In fact, we were raised, as many of you know, as Mennonites. And Mennonites, they somehow have children. But we don't know quite how it happens. And I really didn't know how it happened until I was 19 in nurses training. So that's how naive I was. So we think God had a real sense of humor when we were the ones pulled into this field. So
they actually asked me to teach the class, and because Joyce was a nursing professor at the University of Cal State, I got her, and she's the one who is organized and writes our notes and all that stuff. So I needed somebody to help me with all that, and that's how it got started. By the way, I should tell you that I have a raspy voice, just so that you're aware, because I have one paralyzed vocal cord. We're supposed to have two that go back and forth, but only one of mine works, and that's why I sound like Robert Kennedy Jr.
We maybe should.
That's the end of the similarities. But
And Cliff said I have to admit my aging issue too. So about 10 years ago, our grandson told me that I had a bobblehead like they had a handout at Dodger games. So I have a head tremor. I then went to a neurologist and actually got diagnosed. But that's there.
What happens when you're 84 years old. And I think we get Are we done? Anyway, we've got a lot. Our first part.
We're so happy to be here with you all. We really are.
Our first part is kind of heavy-duty research stuff, and then we'll get to some of the more interesting things as we go along. But let's start with this disclaimer, and that is that we have to let you know that the only way we could profit from this would be if you bought books away from here today.
Because everything we're selling here today will go directly to the
Emotionally Healthy Leaders Fund, so not to us.
Personal. Then we are not researchers. Our findings are observations that we've made as clinicians or that we've gathered from other clinicians who have had observations over the years. We do refer to others' research, and we combined our observations with research information and hopefully somewhat factual, and helpful.
You can follow on the outline, but our first objective is that you'll be able to understand and describe sex and the brain research and sexual response theories and medical interventions that optimize the sexual functioning and enhance sexual fulfillment in marriage. That's our first objective here.
And we tried to put, as you can see, squeeze everything on the outline we handed out so that you have it, but you also can download our slides from our website, passionatecommitment.com, and they are there. We did make some adjustments on them last night that didn't get onto the website, so if you see some differences, that's why.
To give you a context of where we fit into this whole process, we want to start by talking that initially, Masters and Johnson did their research on human sexual response. That came out in 1966. And then a year later, they wrote Human Sexual Inadequacy, which dealt with dealing with the sexual problem areas.
Prior to 1970, the treatment of sexual dysfunctions and problems were generally the province of psychiatry.
Very often, even the long-term psychotherapy that was, 4 days a week for 5 years. And one of the interesting things about that was by the time you were finished with those 5 years, you thoroughly understood why you were struggling with erectile dysfunction. You were still struggling with it, but you really understood why. And that's why sexual therapy came along.
And then in 1974, Masters and Johnson had given us the linear model. 1974, Helen Singer Kaplan came out with the new sex therapy. And those were the 3 resources that we had when we prepared for that 10-week series. The 2 by Masters and Johnson and the 1 by Helen Singer Kaplan. And it was spring of 1975, so just a year after Helen Singer Kaplan, that we were asked to teach that 10-week series here to the wives.
And then a year later, we were asked to speak at the CAPS convention in Santa Barbara and do a plenary address. And the religions writer from the LA Times was there, and he wrote an article the next week in the LA Times, big headline, Sex Revolution in the Church. And from our perspective, there was no revolution going on. The whole article
was all about Clifford and Joyce Penner. There was not referred to anybody else in the whole article, and it was like big headlines.
But what happened as a result of that is that got picked up by the International Wire Service. And so all of a sudden we started getting calls like we were experts, and we weren't.
And from Germany and Switzerland and all over, people wanting these famous people who were, and we'd done this for 1 year now. We weren't trained. We just had self-studied. So it really wasn't a goal. You're supposed to have long-term goals. This was not a goal of ours. And I kind of fought it all the way along. Cliff had a hard time dragging me along with it. But it has been so rewarding. We really know and can see how God was preparing us for it when we look back. The first year of our marriage, we spent, and some of you have heard this history, we spent our devotional time together just looking up every scripture that had to do with sex, starting with Genesis all the way to because we thought we were enjoying it, and we weren't sure we should be enjoying it.
Well, I was sure. but
I definitely am always the cautious one. I always follow the rules, and I wasn't sure. So we just went through and studied that. I remember being in this, to tell for our Mennonite friends who are here, being in this we spent a summer in a little church in Grunthal, Manitoba as pastors that year. And I remember doing our Bible study time during that. And here we are in this little Mennonite town studying scripture and sex.
So people started asking if we could meet them to do sexual therapy. And because we had not any training, we said, we're not sexual therapists. Many of them said, we want to see you anyway. So then we did get trained, went to Masters and Johnson and other places so that we actually had some background in terms of dealing with this. And it was in that context that we developed our protocol for doing sexual therapy that we still feature today.
We later learned that Masters and Johnson had actually planned to use all this research they had done to develop the protocol for sexual therapy, but they messed up, even got their lives in a mess before they got to that. So we were the ones that did that, and others did that too. But we did it from the faith-based perspective.
And then there were other leaders that came along that many of you are familiar with, like Bernie Zilbergild and Lonnie Barbach and Harville Henricks, Snarch. All those added to our education. And then sexual therapists go to interesting conferences. We had a conference in 1998 that was the International Men's Sexual Dysfunction Conference. And there, the emphasis, by that time, that was in 98, the emphasis had changed from being psychologically focused to very medically focused. And much of the research has confirmed that over the years.
In fact, it was very much just a flip. When we studied with Masters and Johnson, Master had said that 85% of the time erectile dysfunction was due to psychogenic causes, and 25% of the time to physiological.
By the time we got to 1998, there had been a complete flip, and the experts were saying 90 or 85% of the time there's a medical cause, and 15% of the time it's just psychological. So,
and that's one reason that we make sure when someone comes to us, especially a young person, just had a call this week, newly married 40-year-old male, and having erectile dysfunction. And the first thing we ask is, was there any history, like a father who died of a heart attack, all that? And we always ask them to get a medical workup, cardiology especially. And we've actually saved lives that way from men going and getting a bypass surgery. So that's a very important part. The sexual response graphs we're going to share with you really help us understand and reflect the various theories.
This one is one you're probably all familiar with. This is the standard Masters and Johnson one, the 4 phases. The excitement phase, which references the initial excitement of erection for the man, vaginal lubrication for the woman, and then the plateau phase, which is everything from that initial excitement to the point of orgasm, which can be very brief or an extended time.
That's the phase that varies most in a quickie versus a long-term love play.
And then the orgasm, and then the resolution where everything goes back to where it started. Another way that Masters and Johnson pictured this was like this, and that middle plateau phase can be quite long. They also did another variation on this, and that's where they, on this top diagram, they show the possibility of a man having an ejaculation, and then relatively few men can have another one within a very short period of time.
You can see where the red line is going down. He's losing the erection, and then can be on the dotted blue line, stimulated to a new erection and another orgasmic response. But that's rare for men.
On the
That's
bottom,
not common.
On the bottom, the yellow line would picture a woman who behaves very much like a man, who gets very aroused and responds quickly. And then drops off. And then, but the other difference between men and women is that women can more easily have multiple orgasms.
As the blue line shows, and then the red line is the graph for the woman who gets aroused, and in that plateau phase, just kind of runs that phase and can't make the shift from what you'll see later as the parasympathetic nervous system to the sympathetic, from the passive to the active.
Now, Kaplan came along and talked about the triphasic model. She added that dimension of desire, the interest that precedes sexual activity.
The motivation or anticipation of a sexual experience or of a sexual arousal. And then she combined the arousal with the plateau phase and called the whole thing arousal or vasocongestion.
More recently, Rosemary Bassan out of Canada came up with the circular model. Now, we're not going to hope you to understand all this in 2 seconds here.
Just to kind of give you a framework to think about it. And that's most representative of females with sexual dysfunction. And they feel very helped with going through this with them, because they feel like they're finally understood, because it incorporates the need for intimacy. It acknowledges that desire can be responsive to someone or something else, which is true of most models, or that it can come either before or after arousal.
Yeah,
that's the new factor.
The distinction here that she makes, and that is that interest may arrive after arousal rather than before arousal.
Or desire. And that, for us, and that's pictured here, is this more complicated. But you can see the yellow with the sexual arousal, and then goes to arousal and sexual desire.
See, most of us think of the sequence being desire, and then arousal, and then orgasm. And she talks about it in terms of arousal first and then desire.
And that really
we're
depends.
talking very simplistically here.
Yeah.
There's a lot more detail than that. But
That really depends on how you define desire. We think of desire as anticipation, and that would be more that the arousal's there, so she's enjoying it, and therefore she feels like it. But it isn't the anticipation of it. So we don't kind of go with that model unless it's helpful to someone.
But the way we like to talk about it is that that desire is distinct from arousal, and that it's the positive anticipation of the sexual activity.
And one of the things we often, when a couple comes to us, is we want to find out, is there positive anticipation of sexual experiences? Because that's a big factor. If people are dreading it or not positively anticipating it, that's important to know. And then sexual arousal, we think of as that physiological response to sexual stimulation, which sexual desire is more the anticipation of that response, not the response from our definition.
The way we would talk about it on our last point up here is that sexual desire may lead to arousal, but it's not a prerequisite to it. A couple can engage in sexual activity, and then the arousal will occur. So we talk about that as having a sexual experience by decision rather than out of desire. And that's a distinction that we often make with couples because they're looking for the desire to be there, not recognizing that the pleasure may be experienced if they get into the experience, having done that by decision.
We also want to differentiate between having it by demand versus decision. We want to eliminate in going into a sexual experience because of demand on the person themselves or demand from the spouse or the partner.
So let's talk about that graph that's on the third page of your outline at the bottom, and we'll show it on the screen here. But just to orient you.
This is an overlay graph that we have developed over the years, and the first thing we look at is the physiological sexual response cycle. And the PNS refers to the parasympathetic nervous system, which is our passive branch of our involuntary nervous system. It's more the relaxed, soaking in the pleasure, enjoying the moment. And then that as we move from plateau to orgasm, our body has to shift to the sympathetic, which is the active, go after. And many times men struggle more with premature ejaculation, getting there too quickly because they're more active is one reason we would find that to be true. And women have difficulty making that shift because they're more passive. So for women who get stuck on that wavy red line that we looked at, one of the first things we encourage is for them to get very active in the sexual experience rather than waiting for it to happen to them to go after.
Now, we should explain that this physiological response will be the same whether the arousal and orgasm is a result of self-stimulation, masturbation, or mutual manual stimulation or oral sexual activity
Any form of stimulation.
Or intercourse. The physiological response is the same in all of those variations. Now,
it can even happen involuntarily during sleep, the whole response.
Emotionally, it may not be experienced the same, but physiologically, all of those are identical. So let's talk about these phases.
All of us have ongoing involuntary sexual responses. Men have erections every 80 to 90 minutes while they sleep during their reproductive healthy years. Not always go the same as we age. We're both getting there in that age. And then, so that's a natural response.
And women lubricate vaginally every 80 to 90 minutes while they sleep during those healthy years. And then the excitement phase, obviously, is that initial arousal, and the plateau phase, all the love play that happens between the initial arousal and orgasm, and then going back to the pre-stimulated state.
Once we give that release, then our bodies let go, and we have the resolution of the arousal.
Now, if we look at what goes on emotionally, relationally,
alongside this physiological response, it starts with that desire, that anticipation of sexual activity, that longing for. It can be in different ways. The initiation,
means taking action on that desire.
and we'll see that described more
And
in a
then we
moment.
like to focus on pleasuring rather than foreplay. The foreplay word has gone out of vogue these days because that sounds like what you're doing before you have sex. And the foreplay is actually very much a part of the sexual experience. And so we much prefer to talk about that as the pleasuring phase, and that naturally leads to arousal. And then we like to talk about entry by invitation. By that we mean that the woman initiates the activity rather than that the man. But we should note here that for many women, they may experience an orgasm even before they get to entry from the manual clitoral or oral clitoral stimulation. So that varies from person to person.
In fact, most of the research indicates that around 67 to 70% of women never have orgasms from during intercourse, but only from external stimulation.
And then there's the orgasmic, the letting go response, and then the time of affirmation. Now, our colleagues, Scott and Melissa Symington, have come up with another way of describing that.
One of your professors here teaching this, and this is a great way, and we've kind of talked about that the desire can be an urge for touch, for closeness, for arousal, or for release. It doesn't have to be a necessarily one for specific sexual arousal. And then initiation is acting on that desire, freedom to enjoy each other's bodies for our pleasure without demand during that pleasuring time. Scripture talks about us giving ourselves to each other in a free way to enjoy each other freely.
And then a natural consequence of the pleasuring is the arousal. And then we get to that point where we strongly encourage that it is the woman who determines when entry takes place, because it is her body that's being entered. And it really works best if she determines when she's ready rather than he determines when she's ready.
Physical signs of readiness may not always be fitting with her emotionally readiness.
And then we talk about enjoying the process, which is not goal-oriented. It's not designed, it's not aimed at getting aroused or aimed at having an orgasm. It's aimed at enjoying each other. And then the consequence of that is, of course,
the letting go. And the orgasmic response has been compared to having a convulsion in terms of how out of control we are during an orgasm. And that's why some people who have high need for control have difficulty letting go.
We'll talk about that in a minute when we talk about the adult children of alcoholics.
Mm-hmm.
And then the time of affirmation is an important time of connection, particularly if there's been some difficulty along the way.
But when we've had that kind of out of controlness with each other, that's why we need that closeness and affirmation afterwards.
Now, the third line here is in the red, and here we're talking about the dysfunctions that fit into each of these categories.
And these are when we're training sexual therapists in a 30-hour weekend, this is where we would get into in detail on all these, how you treat it, how it shows up, all that, which we're not here to do today.
About 40% of the people who come for sexual therapy fit into this category of difficulties of desire and getting into the experience.
Or differences. And when there's a difference, when one person wants it more than the other, it can be a small difference. And usually we ask the couple to separately answer, how often would you like to have sex, and how often do you think your spouse would like to have sex? And it's common for the one who wants, and it can be a very small number, wants it more, will say, well, I'd like it, 3 times a week, but she or he probably never, maybe once a week, maybe once a month. And then the one who wants it less will say, oh, he wants it all the time. That's all he ever wants. And well, I'd like it twice a week. You know, he maybe wants it. We're using the traditional. Sometimes it's the opposite gender, but he wants it 3 times a week. She wants it twice. But he's always initiating because he wants it a little bit more often.
And
So they both think that he wants it all the time, or she thinks he wants it.
he's working on odds. You know, that the hope is that somehow he will find that window of opportunity, and he'd hate to miss one when she's open to it. And so then she feels like that's all he ever wants. But
So just having them answer that question separately and see their answers is a deal breaker. I mean, it just is so amazing what the change is that happens quickly for them.
when we talk about the approach avoidance pattern, this is one where
That would come out of this, what we've talked about.
where one person is always the approacher and the other then was the gatekeeper, and this often happens before marriage and then often continues into marriage. And so when we find that pattern, that's one we want to reverse, because the person who's always on guard, he's always going to be wanting it kind of thing, needs to be able to shift so that the initiation can come from her if it happens to be the woman.
Boredom and inhibition and spectatoring are things that typically happen when the couple doesn't do a lot of communicating and talking to each other about the sexual experience, and just have gotten into a routine, and it happens the same every time. I remember years ago we did a 11 o'clock news during sweeps
Month, yeah.
and somebody presented the idea that the most common lovemaking time was after the 11 o'clock news, and it took 5 to 7 minutes. And that's the kind that leads to boredom. And inhibitions can be things we bring in. Spectatoring is
What we mean by spectatoring is the person who kind of gets outside himself and watches how he's doing. He may be watching whether he's getting aroused, or watching whether he's getting her aroused, or whether she's as enthused this time as she was last time, all those kind of things.
And if you're an English major, you may know that the actual technical word is spectating, but spectatoring is in the dictionary as having been coined by Masters and Johnson and accepted. So
Just that's the tidbit you can walk away with.
yes, that's it. Deep learning for today.
Yeah. Primarily, it's men who struggle with the arousal phase. The interesting thing is that the research has shown that even if the woman doesn't recognize it, when there is sexual stimulation, she may be physiologically aroused, even if she doesn't have an awareness of that arousal.
For men, it's much more obvious. For women, it's not so obvious, and they aren't that aware. And in fact, I think there was a study just recently that we did not include in this in Toronto that also said that about orgasm, that we used to think if a woman didn't know whether she was having an orgasm, she probably wasn't. Now it was showing that many women who think they're not having an orgasm actually
have the physiological response of an orgasm, but not the emotional pleasure part of that experience.
And so there is more pressure on men for erectile functioning than there is on women for vaginal lubrication. You know, we can use a lubricant. That's a lot harder for men. So we think that's why there's more ED than there is issues of lubrication, unless it's a hormonal issue.
This title, the
Genitopelvic penetration disorders.
That's now the DSM-5 label for women who have difficulty having allowing entry
or have pain.
And
genital pain.
We used to call this just dyspareunia. That's the other word that is used. But that usually happens around the time of entry or attempted entry. And then in the orgasmic phase, this is an area where a lot of women struggle either being aware of it or letting themselves experience that, because it is difficult for them to shift from the parasympathetic to the sympathetic nervous system, where they go over the edge.
Delayed ejaculation is the new term for DSM-5, but we feel like that's very inaccurate. Is it delayed if the man has never in his life had an
It's
ejaculation?
just
He's
a
now
long
30.
delay. But I suppose so that
It
way,
used to be called inhibited ejaculation, and we think that's a much more accurate. We don't know who was on the committee for that, but I don't know that they were a sexual therapist. And that's probably one of the hardest to treat because each situation is so unique, and we'll talk about that for men who are not able to ejaculate. And the most important thing is to find out what was the situation with their first ejaculation? What memory do they have of it? What happened? What was the stimulus? And sometimes it'll take a long time to get that. If we're working with a couple because he's embarrassed with how it happened and he doesn't want to admit it because it's so uncomfortable for him. So
premature ejaculation is the most common dilemma that men deal with. By that, technically, we mean that ejaculation happens before entry or immediately upon entry or within a very short time, sooner than the man would like or that the woman would like.
again, we think that's because the man is much more with his sympathetic nervous system, the act of going after.
In terms of the affirmation side of this, I think it's just good to talk about the crying part.
Oh, yeah. So many women have gotten into the pattern when they have not had an orgasm of crying, and they feel they don't want their husband to feel badly, so they turn away. And the crying is actually the body's way of releasing and helping the shift from the parasympathetic to let down because they never got the release with the orgasm with the sympathetic.
So it provides a release. It's not as much fun as an orgasm, though, because
But we encourage couples, when we hear that and find that out in the assessment, to share that moment with each other and hold each other so she learns to let go with him, even if it's with her tears, and to teach her that it's not a sign that she's disappointed. It's more a sign that her body.
She may be disappointed in her body, but not necessarily disappointed in him. Mm-hmm. And then across the bottom, as you can see, I don't know if you can even see that stuff. That's too bad. Anybody that struggle with a sexual addiction, particularly something like porn or whatever.
You can all turn around and see it better on the screen behind you. We didn't realize it didn't show up there.
So if you understand all of these phases and everything in the red and know how to work with it, you're a sexual therapist. And so we were delighted when we finally came up with this graph because it somehow pictures everything that we do and need to know. You want to talk about?
Yes. Oh, there is a website, and it's on your outline, so you don't have to get it down, where if you want any other diagrams or graphs or explanation of various response graphs, you can go to that website.
Now we want to shift to talking about sex and the brain.
Which the studies on sex and the brain came out in 2007 in a textbook edited by Gillian Einstein. It's a collection of research articles, 2007. And we learned a lot. First, we want to look at how sex can impact the person, different effects it can have on us. And sex is like a drug. It's the pleasure we get from sex is largely due to the release of dopamine, a neurotransmitter that activates the reward center of the brain. And dopamine is also one of the chemicals responsible for the high that people get from drugs, or even caffeine, nicotine, and even a little bit from chocolate. I'm a chocolate lover.
So,
Love it.
and then sex can also act like an antidepressant. In a study out of University of Albany, they measured 300 women and found that those who had sex without a condom had fewer depressive symptoms than the women who used a condom. And the hypothesis was that the various compounds in the semen, including estrogen and prostaglandin, I can never say that word, had antidepressant properties, which were then absorbed into the body after the sexual experience. So that was an interesting.
So it can act as an antidepressant, but then there's also a syndrome called postcoital dysphoria, which is a condition characterized by feelings of sadness, anxiety, or depression that may occur after sexual intercourse.
And there's been research on this, but
Nothing
nobody has
conclusive.
really good understanding of what's behind that. But that's still the case.
Sex can relieve pain. Don't skip sex when you have a headache. Then you may give that as a reason. But a 2013 German study, 60% of participants who had migraines and 30% who had cluster headaches, who had sex during a headache episode, reported partial or total relief of the headache. So that's a new treatment for migraine headaches.
Yes. And you don't have to go see your doctor about it.
No, well, maybe you do.
I suppose.
Other studies have found that women who stimulated an area in the vagina that's controversial, the G-spot area, had an elevation in pain threshold. It took greater pain stimulus for them to feel the pain. Most of that research was done by Beverly Whipple. You may have heard that name.
That was done in 1981, and her most recent report on that was in 2014. Sex also boosts memory. This is an interesting thing. The research has shown that people have...
It suggests a correlation, not a causal link, between regular sexual activity and enhanced memory, particularly verbal recall. It's thought to be due to neurogenesis in the hippocampus and heightened blood flow to the brain and release of mood-boosting hormones, which we've already mentioned.
And then it also calms us and reduces stress, and the research is pretty good on that.
And that's, again, because of that PNS, SNS, and SNS is your kind of stress go-after mechanism, and if you have an orgasm and get release, then it lowers your blood pressure and helps get you out of that fight-flight syndrome, and which long-term staying in fight-flight is not good for our bodies.
If you want to say this, Joyce.
Stress symptoms were found to decrease with the increased frequency of sexual intercourse among young women. A study was done of 18 to 20-year-old women, reported in the Journal of Sexual Medicine in 2015.
And then the last point here is about this whole idea that men fall asleep after an ejaculation.
And for years, we dealt with couples about that and helping the men take responsibility for himself and stay connected and all that. And then the brain research came out and said, well, it's due to the fact that he has a big surge of prolactin and he's going to fall asleep. It makes him sleepy.
So there's a
We thought it was
biochemical
neglect.
reason
It was a
for that.
behavioral issue.
Rather than, and she thought he was just such a cad. All he wanted to do was get his jollies and then he falls asleep, And that's just...
So
there may be some truth to that, but the fact
not
is,
necessarily.
but that there is a real cause for it.
So those are some of the impacts on us as people. The sex and the brain studies really did inform our sexual therapy practice. There were changes we made as a result of what we learned. Understanding sex and the brain makes a difference in sexual therapy. We found it greatly helps with male and female similarities, embracing those and differences. We find that the brain studies actually showed we, as men and women, have more similarities than we thought we had. And
yet there's a real difference between us. The way we have come to think about it is that it's the man's simplicity and predictability and the woman's ever-changing complexity that is the key to keeping sex alive, because he's always off guard. He doesn't quite know where to go because she changed from last time. Last time she really liked this, and today that isn't what she likes. And so what's a man to do? Well, he's got to just keep trying for a whole lifetime. That's exaggerating to make the point.
62 years of marriage, and he's still not got it.
Amazing.
And it also helps us make the big finding. was helping make the transition from the initial excitement of a new sexual relationship to the long-term attachment. And that is so key. For you who are counselors, you've probably had couples come to you at some point, after the first 6 to 18 months, I think it is, that the studies show that newness dopamine wears off and they have to make the shift to the oxytocin bonding. And the couple will come in and say, I just don't know if I love him anymore, or I just don't know if I love her anymore. And they associate it with love rather than making that shift. And particularly it's really made a difference in informing us for men who have found their release through pornography and now are trying to function in marriage. Because pornography is a dopamine drug, let me tell you. And there's no way marriage can match that.
Long term.
And so more young men are experiencing ED that were used to getting their release through pornography and now can't function with a woman because they're dependent on that dopamine surge.
Alan Shore at UCLA talks about excited love, or I would say excited arousal, which is that newness, that attraction, that's the sympathetic nervous system side of the equation, over against quiet love, which is the long-term attachment that is oxytocin driven, which is our bonding hormone, and that is more dominant on the parasympathetic side.
And the formula for intimacy card that we hope each of you picked up when you came in, along with your outline, we created this before. We didn't have it defined like this, but we recommended it to couples based on our clinical observation of what we thought really helped couples.
This is not a formula for having sex. This is a formula to build the intimacy between you.
Very helpful for couples or for a person who has gotten hooked on porn or can't make that transition from the newness to the attachment. And we had used this in therapy, and then the research showed why it worked. So we increased the details of it to connect. And this takes 15 minutes a day, and it can be done with kids around. It doesn't matter. You're not having sex. It's good for our children to see that we take time for each other. I remember our son, who's now 55, when he was in junior high or high school, we always took Friday afternoon as time for each other, and the kids would go to a friend's house or we'd have activities for them. And he said, Mom and Dad, you're not taking time for each other. Is everything still okay?
I think he also wanted to have more free time on Friday afternoon,
Maybe.
But he was doing it to care for us.
Yes. But so it's something that it's good for kids to have us see that we are taking this time to connect.
Let's walk through it. First of all, it's important to connect emotionally. And one of the things that the research has shown that when people look into each other's eyes for an extended period of time, it actually raises the oxytocin level in the body.
That's that bonding hormone that is lasting. So if they're not used to that with each other, and we will find that many times, particularly men who've been on pornography, have difficulty with that eye-to-eye sharing, and because it feels uncomfortable for them, it's too intimate. So we do things like play Google Eyes and have fun with it, experiment with different things that you can have fun with
and then share something affirming. This is not a time to work out who's going to pick up the kids from soccer. This is a time
to work out your last disagreement or your fight. This is a time to just share something positive, some thought you had, some experience you had,
about yourself or about the other person.
And then to connect spiritually, and that depends on where you or the person you're dealing with, client you're dealing with, where they are in their spiritual life.
So that could be a biblical passage or a devotional reading or some inspirational reading or a prayer or whatever works, but some kind of a
bringing God into that intimacy. And then to connect physically. And this again, we encourage them to set, you have your clock on your phone and set it for 20 seconds and then do a full front to front body hug, not a Baptist hug.
Not
like that. but a real front and really hold each other tight for 20 seconds. It's amazing. 20 seconds is quite long.
And again, the research has shown
it takes 20 seconds to get this surge of oxytocin.
It's a measurable response from a 20-second or longer hug.
And then to get the little dopamine charge, we still can get a little spark even after 62 years. Every now and then you get a little dopamine too. And for that, you kiss passionately. And
we're not talking about a peck or a hello or goodbye kiss. We're talking
this is
about
really getting into it. You can incorporate it, right out, keep hugging and then kiss passionately. Now, for someone who had sexual abuse, who was kissed, someone who has trauma connected with kissing, they can't start there. So you start where they start, and the person who has difficulty or experienced the abuse should always lead, and the other one follow. So they might start with just holding their lips together and take very small steps until it's comfortable for the one who has difficulty with that.
That formula for intimacy is we have had many responses where people say that alone made a real difference in our life in terms of connecting. It's been surprising.
And many therapists order it online in packets because they give it to their clients.
Another thing that all this brain research has done is taught us about some differences in using hormonal contraceptives.
When the Women's International Health Study came out, everybody was scared to death of estrogen. And now that has totally changed. And we just were at the American Association of Christian Counselors and had the best seminar on the new findings of estrogen and the importance for women. And because of the scare with estrogen, most oral contraceptives removed estrogen completely or decreased it so much that now women their vaginas are more like a menopausal woman because they aren't getting the estrogen that they need. And estrase cream is totally safe to be used by all women. And if a young woman is on a oral contraceptive that's high in progestins, and progestins are synthetic, not natural, in the hormonal birth control pill. And we would not recommend hormonal birth control at this point for most women. And
you want to talk about this?
Yeah, there are several resources you can use for this. I've used managing contraceptive pill patients and other hormonal contraceptives. We would highly recommend, and so would the medical
sexual
medicine doctor who's a fellow in sexual medicine, Dr. Irwin Goldstein in San Diego, and there's several throughout the world now. Would not recommend oral, but would recommend an intrauterine device, and one there are 3 that have progestins in them that work locally in the body and prevent the egg from meeting the sperm. The copper one, somebody faith-based may not want to use it because it gets rid of a fertilized egg. But the progestin IUDs actually keep the meeting of the egg from being fertilized. And that's what he would recommend. That's what we recommend because of that. But then achieving hormonal balance for women of all ages and stages of life. And just recently, I just added a resource on your resource list on page 4. And it's by Stephanie, and I've never heard her name pronounced. It looks like Fabian. And it's the new rules of menopause. And I called the medical sexual medicine doctor who gave the presentation at AACC and asked, of all the resources she used, which is the one she would recommend, I recommend to you all. And that's the one she'd recommend. But the one thing she made very clear, whether you've had breast cancer, all that estrase cream is safe to be used by all women.
So the benefits of this
Transdermal hormone replacement therapy, not oral, protects and promotes heart health. It reduces cholesterol, helps your liver regulate cholesterol. It strengthens bones, reduces risk of osteoporosis, helps our skin, brain, body temperature, emotions, memory function, and libido. So there's a lot more saying the benefits totally outweigh.
a couple more medications we want to talk about.
But always, just a disclaimer, always choose a medical doctor that you feel is up to date and stick with that person, given your situation.
We've got a couple of medications that we want to talk about, and then we'll be done with this part of the brain stuff.
Yeah, Addie is a prescription non-hormonal pill that can be taken every day at bedtime that helps with hypoactive sexual desire for women.
It's been broadcast and written about as the female Viagra, but it's very important to understand Viagra is about arousal. This Addie is about desire. Its focus is on desire, not on arousal. So it's an important distinction to make.
Intrarosa is a steroid indicated for the treatment of moderate to severe dyspareunia,
Pain.
a symptom of vulvar and vaginal atrophy that's common for menopause or for young women who are on the high progestin birth control.
And then you should be aware of ISHWISH, the International Society for the
Very
Study
helpful
of
resource for you to have.
Women's sexual health.
And that's, you can find a provider who's up to date, and
This list is on your outline, so you don't need to worry about copying it down. What else?
now what we have to look at hormonal issues for men as well, and working with the medical team is key for us. It's such an interdisciplinary work, sexual therapy is.
The picture is
Very
this,
integrated.
that a man reaches his peak of testosterone production between age 20 and 25, and then that decreases at roughly a 1% rate per year. So by the time you're 75, you only have half of what you had. When you get to be 120, 125, you run out. And then what's the use of living? So then you die. But that's the way it goes for us as men. This is an average, of course. Some have more, some have less. Another way to look at this is the difference between a high testosterone male and a man with low
Looks
testosterone.
pretty sad.
But that kind of gives you a quick picture there. What else do we want?
Current choice androgen deficiency means the body that's low testosterone has lower levels of the male hormones, particularly testosterone, that is needed for good health. Androgen deficiency is treated with testosterone replacement therapy.
And generally, up to now, that has been like a gel, like something called androgel that is put on the body. But more recently, there's now
Well,
been...
we should say something about, sometimes injections of testosterone are used. The satisfaction with those we find is mixed, because there's usually a big surge and a lot of irritation, kind of hard to live with that when that testosterone's that high. And then it goes down, and then it goes like this and not a steady, whereas the androgel, which is used every day, and then there are other transdermal methods. But the most recent, in fact, our new book, Counseling for Sexual Disorders, I was so determined to have every new thing in that book before it.
And then
we sent it off.
discovered this
And then we
after.
discovered this after that from Dr. Erwin Goldstein, the one in San Diego, that there's a new version of androgen replacement recommended.
The reason they haven't used pills, medication, oral medications, is because of how it affects the body. But this particular one,
Even though it's oral, taken orally, it bypasses the lymph system and avoids the portal system and the liver. So it doesn't cause side effects. The other problem is, though, it's very expensive.
yeah, insurance won't pay for it, and the
So you
cost
gotta
cost is very high. So you can only recommend this to your rich clients. We should just say a word about Dr. Goldstein. This is a resource that you should all be aware of, whether you're a sex therapist or not. He is a medical sexual medicine doctor down in San Diego.
He was a fellow in gynecology, a fellow in urology, and then a fellow in sexual medicine. So
And he is willing to do consults for 15 minutes for free every day.
from 5, I think he's here in San Diego on our time zone. I think it's from 5 to 6.
And you make an appointment, and then your time is for 15 minutes. And he's very helpful in guiding people in various directions on this. So a really good resource.
You can tell him we referred you if you want to use our name, because he
particularly likes Joyce.
Well, I just talk his language, that's all. But he wrote one of our friends he said, "Oh, we love the Penners." So we're very happy we can work with him.
Sexual dysfunction can be any problem that prevents a person or a couple from experiencing a sexual fulfilled activity. And up to 43% of women and 31% of men report some degree of sexual dysfunction.
And that came out of the Cleveland Clinic, that information.
So
Now we can move on to objective 2, which is I'm going to move faster than objective.
Well, you know what I think would be a good idea?
Stand up.
Why doesn't everybody stand up?
Shake your feet a little bit. We'll get a drink of water.
For those of you that can stand. I'm going to close this one. And I'm going to open this one so it's ready for me.
You're going to read the objective? Grab another one.
Oh, well. Okay. Think this is going to work? What's that? Think it's going to work? Okay, good. Okay.
We made it through the hardest part.
I hope so. Thank you.
Okay, so on to objective 2.
Why don't you read it?
Participants will identify attitudes and expectations of men and women toward their own and their spouse's sexuality, as well as gender-related roles and responsibilities for sex and marriage that promote sexual fulfillment and factors that interfere.
We're often asked, well, since all you do is talk about sex, is that the most important thing in a relationship? And we would say, no, it's not. We believe that the covenant commitment is kind of the machine. It's a key component to the relationship. And then effective communication is the fuel. It's the gasoline in the engine that keeps this all running.
And a mutually satisfying sexual relationship is the lubricant that keeps the machine running smoothly.
It's kind of like the oil in the engine.
And you'll probably find when you're working with couples or even on your own relationships, when the sexual part isn't working well, there's more edginess and tension with each other in other areas as well.
So we want to talk about some roles and responsibilities between men and women that, from our perspective, promote a mutual sexual fulfillment.
And these come from our clinical observation. And one is that men typically get turned on by a turned-on woman.
Yeah, it is, or get more turned on by a turned-on woman.
And that's why pornography is so effective. You know, the man can keep flipping channels till he finds the woman doing what he wants her to do. And that's certainly not the mentality we want for sexual man in a sexual married relationship. And sometimes this is important if you're doing premarital counseling. In today's world, it's not likely you're going to have premarital counseling with a virgin couple, but sometimes that still happens. But if a man would be excited to see his wife stimulating herself, most men, but a woman might be pretty threatened by that or fearful or scared, freak her out. Becomes
so that's summarizing men. There's a lot more to it than that, but women tend to get turned on when they feel good about themselves. And that's really a distinct difference we want to be sure you catch as we go along talking
And
about
unfortunately, so often when the man would really love it if the woman was turned on and into it. And when she isn't, he keeps working on ways to try to fix her. Well, the more he tries to fix her, the the worse she feels about herself. And so the less she's going to be excited about being in a sexual relationship.
So we believe that it's the man's role to affirm his wife for who she is as a person and for whom she is sexually. And this is really confirmed in the scriptures in Ephesians 5. This is from the Message, where it talks about husbands, go all out in your love for your wives, exactly as Christ did for the church. A love marked by giving, not getting. Christ's love makes the church whole. His words evoke a beauty. And then everything he does and says is designed to bring the best out of her. And then it ends with, and the husband is really doing himself a favor when he does this. Now, why is that? Well, because when she's feeling that good about herself, she's going to get turned on, and then that's what makes him feel good. So he's really doing himself a favor. It's an interesting little phrase there in that passage that you wouldn't have expected to see there, but it somehow, and you see, Paul here is talking about the relationship between Christ and the church and the husband and wife sexual relationship. In fact, he quotes Genesis 2:24.
Right at the end of that.
Where he says, therefore, a man leaves his father and mother, clings to his wife, and the two become one flesh, which is the first reference to a sexual relationship in the scriptures.
And then if we look at Philippians 2, one of my favorite passages, think of yourself the way the way Christ thought of himself. He set aside his privileges. He gave up his rights and became human like us to get with us where we were.
So when it talks about the husband loving like Christ loved, the idea of setting aside the privileges of the man, and we often hear, but isn't it my right to get my sexual needs met?
He gave up his rights.
And George Gilder, an anthropologist out of Harvard, wrote a book, Men in Marriage, in 1986, and then it was just rewritten 2 years ago. And he says this, it is the man who makes the major sacrifices. The man renounces his dream of short-term sexual freedom and fulfillment, the dream of his male sexuality and self-expression, in order to serve the woman for a lifetime. It is the traumatic act of giving up his most profound yearning, his bent for the hunt and the chase, for the motorbike and the open road, the immediate excitements. This male sacrifice is essential for civilization. And it's really an interesting presentation of how it really works best to follow that biblical model. And here Gilder is not even talking about this from any kind of spiritual success.
Or sociologically.
Yeah. And he goes on then to talk about how a major task in society is to tame the wild barbarians, that is, the men between 15 and 30. And to the degree that the society can tame those 15 years, the society will be successful. It's an interesting concept, a whole thing we could go on about. But so
the man has the key to the woman's sexuality, affirmation. And when he can grasp that and get that, and that's what we have really unpacked in our book, The Married Guy's Guide to Great Sex. And some of you may have seen that's come out under a number of different titles. It first came out under Men and Sex, and then The
Way to Love Your Wife.
Way to Love Your Wife. Then, anyway, now The
This is
Married.
it.
Yeah. Whatever.
Yeah. So we think it's a key understanding for fulfilling sexual life. Then let's talk about the woman's side.
The woman's role is to embrace her sexuality and share her enjoyment with him. And that's what is so modeled in the Song of Solomon. And we have couples read the Song of Solomon out loud to get each other in a, like the Living Bible or the Message, and it's really a fun thing to do. On my bed, night after night, I sought him whom my soul loves. I am my beloved's, and my beloved is mine. My beloved's kisses flow from his lips to mine. Come, dear lover. And she is inviting him as we talk about.
That's the model, the Song of Solomon model, if you read it. Most of the passages are about him affirming her, telling her how much he likes her hair and her breasts. And he even likes her belly like as a heap of wheat, which I don't know that that's the current
California
culture. But he even like that part. And so he is very affirming all the way through the Song of Solomon, and she does most of the money. Come on, she's saying, let's get going. Let's go see if the pomegranates have blossomed. And that's what it's about.
So for passion and marriage, a woman needs to be able to take, to believe she's worthy of touch, and has the right to be intensely sexual. And many women in the evangelical Christian church have been taught their job is to keep her husband at home and happy, not
to get with their own sexuality, but
and the
please him.
best way he'll be happy is if she gets with her own sexuality.
She has to be able to enjoy it herself and enjoy her husband's enjoyment of her as well.
And that we unpack in our book, Enjoy, and we often sell those two as a set. And we encourage couples to read them out loud together.
Yeah, let's
it really
pause a
makes
moment
a difference.
To bring about change between a husband and wife dealing with the sexual issue. We find that if they're willing to read the books out loud, the books almost function like a
third party,
a therapist there, because they know that the book isn't written about them. So the man can say, well, that's exactly how I experience, or the woman could say, that's what I feel from you, or vice versa, and all that.
Or they can say, I don't think that's us. They can talk about how they're different than what we say, but it gives them a way to talk and respond that many couples haven't developed.
So reading out loud, and what we suggest is not each taking the book and going by themselves and reading it and then talking about it, but out loud together. Another thing that helps is it helps them say the words that they're maybe not all that comfortable using, because a lot of couples don't have a sexual language that they can use in a natural kind of way. Basically, what we're pushing here is that sex, if it's going to be good for a lifetime, it has to be as good for one as it is for the other. And this whole concept of mutuality is very much a biblical concept. 1 Corinthians 7, where this is the passage that Paul is answering the questions from the Corinthian church. And
they're asking, is it good to have sexual relations? And he says, certainly. But marriage is strong enough to contain, our sexual drives are strong, but marriage is strong enough to contain them and provide for a balanced sexual life in a world of sexual disorder.
And so he was talking about the world of sexual disorder 2,000 years ago, and we can talk about a world of sexual disorder today. Then he talks about the marriage bed must be a place of mutuality. The husband seeking to satisfy his wife, and the wife seeking to satisfy her husband. Marriage is not the place to stand up for your rights. Rather, it's a decision to serve the other, whether in bed or out. And this is just a core teaching throughout the New Testament about the sexual relationship.
Then when we look at how we saw Masters and Johnson graph of the man and the woman in more detail than we're showing it, but if we do a simplistic one, men typically, if they haven't learned to ride the waves of arousal and let that plateau phase go on for a long time, they typically get aroused and go directly to an orgasm, ejaculation, and let down.
The fact is that most men learn their sexual pattern by masturbation, usually starting at age 12. And so the fact is that this is what happens in masturbation. And yet this is what the woman's graph looks like. And these two don't overlap very well. And it isn't that you can talk a woman into being like a man. The only way it's going to work is if you can help the man
to ride the
get
waves
with
with
the
her.
woman. And he doesn't lose anything by that. He actually gains, just as Paul said. He's really doing himself a favor.
So since the man isn't truly satisfied unless the woman is, he has to shift his goal orientation to her process, enjoying the process together. Now, something that we have found, and it kind of came out of the sex and the brain research, but just also out of our clinical experience, is that sexual responses are easily
we missed-
conditioned. Did we miss that? Oh, okay.
Oh, yeah. Just going back one step,
Okay.
I was slow here. As the husband moves in the direction of the wife's natural tendency, her heart opens to him, and then her sexual attraction to him increases, and then this leads to an experience without demand, and fully enjoying each other that is satisfying for both.
Now, are we ready?
Did I catch up? Oh, one more.
I'm not sure we had those in there.
Well, they're there now.
Okay. Keep going.
The girls put them in there. The summary is that the husband adores his wife. His affirmation ignites her passion. She invites him sexually. Her invitation validates him, and then mutual affirmation is the result of that. And that's just the way it is.
Okay.
He said with great authority.
Oh, so our task is to help men become students of their wives and to help women become students of their bodies and their sexuality. Let's say that again. Help men become students of their wives and women become students of their bodies and sexuality.
No, we can get to
The
the part.
imprinting. So page 3 of your outline has a graph or chart. Mastering
And let's
stage-
just talk about introducing this by saying that we believe there are critical stages of development that occur in each phase of growing up. And these are a result of the fact that sexual patterns are easily conditioned and self-perpetuating. That is, what is established deep in us is something that, and this is particularly true with the first orgasm that occurs.
That's why it's so important, because that often is an imprinting event at a critical stage of development. An example is, let's say a young girl is babysitting and there's pornography in the home, and she finds the pornography and she looks at it and it's arousing to her. And maybe she babysits there frequently, and then she starts responding to that arousal.
We're telling actual stories here.
Right. This is a common one to come to us. And she has her first orgasm in response to looking at women's bodies.
Now she's not a lesbian. She's not
Not
not interested in having sex, but for
a
her
woman.
to have an orgasm, she has to fantasize about the woman's body. That's because this was
Got
something
hooked on
that
that.
got developed inside her at an early stage and got imprinted, that then keeps on going. I've got a situation that I'm dealing with that right now with a woman who is struggling in exactly that way. And the dilemma is this: she can get aroused with her husband, but for her to go to the point of orgasm, she has to fantasize about women's breasts. And if she fantasizes about women's breasts, then she feels like she has left the relationship and is now gone off in her own world. So she has a difficult choice. She can either not have an orgasm, or, as she experiences it, and then feel badly, or have an orgasm, but then feel guilty about having pulled away from her husband in her head. And it's a real dilemma. So
We don't want to go through the details of this chart.
I was thinking of maybe just doing two. I've got two
Okay.
examples.
Okay.
Let's talk about the very first one, because you wouldn't necessarily think about infancy as a time that would have an impact on sexual adjustment. But we all know that the bonding that takes place during the first year of life is very crucial. And regularly we have found, particularly men who were raised either in an orphanage or put out for adoption, but they didn't have any ongoing
But also
parenting.
women, like the woman whose mother was hospitalized
That's
during her
right.
first year of life.
And they didn't develop a capacity for intimacy. And so now they have difficulty dealing with the face-to-face, body-to-body part of the experience.
And we find that early stage, when the difficulty happened because of an imprinting event at that early stage, it usually requires more psychodynamic therapy than just sexual behavioral therapy.
Yeah.
So that has to be
Yeah,
dealt
we haven't said that, but sexual therapy in many ways is a very behavioral kind of therapy. And then we often have to add the more dynamic kind of therapy. I'll just pull out one other example. Is this not up there? Oh, there we go. You got this on your chart too. If you look at the school age, one of the things we've discovered is that almost all kids have gone through some kind of exploratory discovery play during their early years. And when that happened in a natural context, they're with a neighbor or a cousin or whatever, and they're looking at each other's genitals and all.
kind of I'll show you mine if you show me yours thing. Nothing traumatic, nothing abusive, just
And then they get
curious.
discovered. And if that is handled in a healthy way, that is, the parents say, hey, we've got to keep our panties on when we play together, but let's look at a book so that we can educate you about what you're curious about here.
It's natural to be curious, and
And so the curiosity gets reinforced with some boundaries. If there's punishment, which there often is, then sex gets connected with something very destructive and negative for them. We've had situations where, one situation which wasn't extreme, but pictures this so clearly, the little girl was spanked and the boy was praised for what a little man he was when they got discovered.
she was now on her third marriage.
And so that's an extreme that doesn't, but there are a lot of times when kids get very negatively reacted to. So all we want to point out
Just
is
knowing that and training parents that it's a very natural thing for kids to explore and discover and be curious about their bodies during that
fact,
age.
out of 100 surveys, 100 autobiographies that we received from a group that we were teaching, 95 out of that 100, when they talked about their first sexual experience,
Well, first awareness of sexuality.
was in exploratory play. It was an amazing number that we were really surprised at. What about this? Observation.
Yeah, that's okay. I said that.
Okay. Oh, we should just say, should we try to explain this? Just skip it.
No, that's fine.
Okay.
Want to get
Gone.
Now, this pattern is one that we have defined, and it's called the insecure, sexually needy male. And the couple will come reporting the woman's lack of sexual desire.
Yeah, that's
Both
why they
see it
come to
that
see
way.
us.
She's convinced that's the problem too.
Then as we take the history, we discovered that initially in the relationship, she had as much desire as he did.
But then something came along, the first child, or she was sick, or she was under pressure for a job,
Or she was having her period.
yeah, whatever. And she turned him down or wasn't interested for a period of time. And he
Which then
got
kicked off
anxious.
his insecurity because his self-worth is determined by her constant, ready interest in him.
And he is constantly watching. I don't think you're quite as turned on as you were last time. Talk about spectatoring or being spectatored. And, it's been, are you sure? Just all that questioning. And what we find is when we take the history, I remember the most extreme, and some of you have heard us talk, we probably use this example because it's the most extreme one we had. The man was raised by a very distant, cold father and punitive, harsh mother. And this is the man. See, men have a little different task when boys do, when they're about between 3 and 5, when they separate from mother and move toward father as their role model. And it's like they're symbolically looking over their shoulder for mother's smile of approval. And for the man who didn't get that from his mother or had traumatic experiences with women, they may now be looking to their wife. And many times these are men who saved themselves for marriage and had high expectations for sex and marriage. And they're constantly watching her for her smile of approval. And her smile of approval is how she responds to him sexually.
So we had a couple come to us, and they were here for an intensive. So when we do an intensive, we give them an experience for tonight and tomorrow morning. This afternoon and tonight, and one for tomorrow morning, and then they come in.
And see them at noon, and then they do that every day for 10 days.
And the first thing they were supposed to do was just read the guidelines. But when they came in the next day,
they hadn't done anything. And it was because, well, he said, I don't think she wants to do this. She didn't read the guidelines with enthusiasm.
And
she
so
couldn't
they
even
shut
get
it down.
past the reading the guidelines, let alone
Because
sexual.
he had such a need to have a response to him, and that's what validates him and makes him feel good about himself. So this is something
It's tricky to identify, but it's good to be alert to that it may be there, because she believes and he's so nice, he's so caring. He's gotten me all these books to help me. And we always say, this is the man who has more sex books than we have. He's purchased and that's one of the symptoms that we see.
So that's one area. Another area is when there has been sexual abuse in the past, and you're all familiar with this. Often there is high interest in sex outside of marriage or before marriage, but then shuts down in marriage very quickly. In fact, couples will often say, well, during the first 6 months, I was really enthused about it, and then I lost interest.
But sometimes it's shut down even as they anticipate marriage. And the reason we understand this to happen is that in marriage, it's now expected. Outside of marriage, her sexuality was turned on prematurely, and she's very sexual. And so often the guy she's dating thinks she's really hot. And as they're anticipating the marriage, she thinks, oh, it's just a wedding planning. I just don't have my enthusiasm anymore. But for sure, they shut down within the first 6 months or so. And because now she feels trapped by the marriage, like she did the trap in the sexual abuse. And so now she can't get her freedom back.
So and again, a big area, but just something to be attuned to. And then another area that we talk about a lot is the ACA, the adult child of an alcoholic, or this could be somebody raised in an emotionally out of control home.
Mother was mentally ill, or father was a rageaholic, or whatever. But the child, again, we should be raised with really good, firm boundaries, but a lot of room to bounce off those walls.
And when you're raised in an alcoholic or out of control home, you develop a high need for control. For those of you that work with,
you have to provide your own boundaries, because the parents are out of control, not providing the boundary for you to bounce off of. So you internalize the need for control far too young, and being out of control is frightening. It's
so
like
this is what the graph looks like. The person, this is more often a woman than man. The woman is very resistant to getting involved, but then at a certain point when her body gets aroused, she might be very responsive and have an intense response, and then drop off right away. And
just because she responded doesn't mean she feels good about it. That's a difference. She isn't happy about that she responded. She doesn't like that feeling. She doesn't want to do it again, which is hard.
So then she'll be resistant. And so there's a pattern. Every time we speak to a group of married couples, we'll have somebody come up and and say, oh, that's exactly our pattern. That identified exactly what's true for us. What are you looking for?
I'm looking for how much we have left.
Oh, we're
because
fine.
We're fine.
Yeah.
Good.
Shoot.
We're going to get to questions.
Okay.
So
Oh,
save your questions.
okay. Some other findings that gave us some new awareness that we found. One area that we've dealt with a lot more in recent years is women who experience pain during a sexual experience.
And pain has and it's always surprising to me that women will keep having sex maybe 20, 25 years, and it's been excruciatingly painful. I mean, how that happens, I don't quite understand from the husband's perspective or the woman's. And help is available. Some situations are easier to help than others, but this is the cycle of pain, and pain perpetuates more pain. And the more they anticipate pain, the more the body tightens up. The tightness makes it feel worse, and the body braces more, and pain reinforces fear and the reflex response. And so it keeps itself going. So the first thing we do, I don't see clients anymore, but I do free 15-minute triage for calls, and I get a lot. And the first thing I do was, before you get this cured, stop doing anything that triggers the pain. Stop any activity that triggers the pain. And she'll say, but how can I? He needs his release. And then we discuss that. But
Okay, we're right here.
they really need to get help for that. So that's all we want to say about that. Now, we want to talk quickly about the whole how you use restoring the pleasure and getting counseling for sexual disorders. They have the assessment tools you need. Can you keep I think we need it here. That's learning objective 3. Okay.
So this is what we want to talk about.
Yeah.
Learn to examine the attitudes and roles in the effective use of the sexual therapy tools available in restoring the pleasure and in counseling for sexual disorders. And we'll talk about these as we go along.
So just to review, 1990, we wrote Counseling for Sexual Disorders as part of the series for Christian counseling series published by Word Books. That series had 26 volumes, and this was one of them. When they stopped printing that, we got the rights to that book and then republished that ourselves through self-publishing in 2005. But we really didn't make much change in it at all. And so now it is totally, we've gone through it. We read it out loud, word for word to each other, me on the computer and Cliff looking at the hard copy, and worked and then took all the research papers we'd been gathering through the years and from Melissa and everybody else. And we think we've covered everything. You may find something you can write us and tell us the next time we print it, we better add that in it. But
so let's start by talking a little bit about this whole area of sexual therapy and sexual retraining.
And we call it sexual retraining and restoring the pleasure because it is designed to be a self-help tool for couples. So you don't have to be a trained sexual therapist to coach a couple through using the restoring the pleasure, recognizing that you use the counseling for sexual disorders to help you know when you're not qualified to do that and when you need to refer to a sexual therapist.
And the whole point of sexual therapy is to reduce demand and enhance pleasure and get couples functioning in a healthy way so that both are satisfied.
And if you've heard Melissa talk about this, any of you at Fuller, and we would concur completely, it is the most integrative approach. It's so rewarding because it requires all aspects of our personhood. Our spirituality, our emotions, our physiology, it's very integrative, and that's why it's interdisciplinary. Also, we need to work with a team. We need to have medical doctors available to refer to pelvic floor physical therapists, the whole realm of other expertise.
In sexual therapy, we have three kind of assignments that we give people. And they're listed here as we often talk about it as teaching, talking, and touching. And the goals in sexual therapy are pretty clear. Distract from anxiety, get rid of the demands, establish new patterns, because usually the couples that come to us have a well-worn pattern that isn't working.
And that's why the guidelines are so important. And going through those guidelines with the couple, whether you're a sexual therapist using counseling for sexual disorders or you're helping the couple use restoring the pleasure, the guidelines, and that is what the first guideline is to no more intercourse or no sexual activity. That's more involved than what the assignment is they have been assigned, because it is a process from hand and foot caress, facial caress, to total body caress, to total body, including breast and genitals, and then eventually to entry right near the end of the process. And the most calls I get from other therapists is, how do you help the couple not have intercourse? And the reason why is, and I explain it now on the website so that people can use that, is that since our body, the sex and the brain research shows that it becomes the conditioned response, and you have to recondition that response. And if you keep your old pattern going while you're trying to learn a new pattern, your brain can't do it. So it won't work. It won't be effective. And that's why the guidelines are key to success.
So these assignments are detailed in Restoring the Pleasure. And this is the book that we think of as for the client. And there are like 31 different assignments that we take people through.
Teaching, talking, and touching.
And then this is the book that we just finished rewriting and came out in March now this year, which we feel really excited about.
And now, in the past, these didn't match perfectly. Now the exercises in counseling for sexual disorder are identical to the ones in Restoring the Pleasure. So they're a perfect match. So you can, and now they're available on our website digitally so that you can get them that way.
So in counseling for sexual disorders, the communication or talking exercises, each person completes those, writes about it themselves, and then they share on the educational experiences. This is helping them learn about things. For example, we have a mirror assignment in there where they stand in front of the mirror without clothes on and talk about their body and how they feel about it. That's just an example of that. And then there are all the touching experiences, which are aimed at pleasure
And are
rather than
progressive.
arousal, and go in clear steps.
And because the sexual experience is broken down into small increments, starting far away from the genitals or stimulation, that is what they come in a very prescribed order, and that's why it's like a prescriptive process. We've talked about.
Oh, yes, let's say this. Sexual therapy is different from other therapy, and that is when you're starting, the therapist is very much in charge. It's a very directive process. It's very behavioral, and it starts with very clear guidelines, and that's what we mean then when we say an in-charge therapist who will direct.
You work out with the therapist in the therapy session. Who's going to initiate? When are they going to do it? What happens if it doesn't happen? Because you don't want them to waste a week and come back and say, well, we didn't do it because I thought she was going to initiate, and she said, well, I thought you were going to initiate. So you want to take all the issues out so that it's planned ahead. They know when it's going to happen and all that.
Then it's very important that there's a very clear way of gathering the data. Sometimes couples will come back from a week of assignments and will say, well, so tell us about how to go. Fine.
So we now have a homework gathering tool, a form that you can actually email to them for each of them to fill out. And then they can send it to you ahead of time and you can look it over. They can bring it to the session, however you function. And so that can be very helpful.
And then The other one is the effective management of the client's idiosyncrasies, relational issues, and I would also say dysfunctional
Right.
personality
Diagnoses.
disorders and all of that.
Yes.
If you're doing sexual therapy, you're going to bump into other issues that will distract you from what you're doing. And you need to kind of get off the sexual therapy track and get into the psychotherapy track to deal with those things.
Or you find them in the initial assessment process and you give recommendations for other therapy before you engage in sexual therapy to deal with those issues. But some issues, like a borderline personality disorder, you may just know you're going to be dealing with that while you're going through the process.
So the way we describe it is that the ultimate goal is to help couples achieve mutually satisfying sexual relationship within the parameters of what's possible for their given situation.
And that's key. You know, it's not we're not into sexual therapy to make everyone have this ideal sexual relationship that's written up somewhere. It's to make a mutually satisfying sexual relationship given their parameters, their age.
For
their
example,
health,
as soon as the
children.
first child arrives, the sexual
Gonna change.
frequency usually drops about 50%. That's what the research has shown. So that's a change, and you've got to adapt to that. Then a second and third and fourth child, and then people working on their careers, and then there's illness to come along, and aging, and decreased testosterone, and all those things that have to be adapted to. And so that's what we mean by finding the best possible outcome given the reality of your situation right now. So those are a bunch of things that we've gathered over
share
the
with
last
you.
50 years.
And we have time for questions.
We'd love to get you to ask any kind of a question you want. We've got microphones here.
And there. Thank you.
Thank you. So you can ask any question, and you can ask it about the person sitting next to you, so that,
You know,
or I have a cousin.
in Milwaukee.
Go, you come up to the mic so we can hear it. Go ahead, Gail.
Well, I'm probably the only person here that I was in one of those seminars 50 years ago.
I know.
I was a student. As I'm listening to this, I guess my question is just more of, as a couple works their way through this and as a couple matures, there's a part of me that says the dynamics of the stereotype you're presenting, in some ways, I would think modulate a bit, so that they're in that over time, the roles, it's not that they change, but there has to be an appreciation of there being room for the couple to be talking about the man's sexual experience. And just as you were, when there's dysfunction and when we're young, but as time goes on, isn't there...
You're talking about like the role of the man to love his wife like Christ loved the church, and the role of the woman to get with her sexuality.
Is there a way
that changes as we age.
as we age, and just the wisdom of time, as well as a couple's ability for the man to say, explore his sexuality more fully, and you can talk about him.
Some younger couples are actually better at that than older ones.
Okay.
But I think you're right.
But what,
You may have done it well. So you heard us 50 years ago. So
I've just been thinking and practicing ever since.
That's good. Well, what I was thinking about there is that that somehow the reality is we're working with couples who are not at that advanced place, and so you're talking about the long-term outcome that we hope well beyond even when they're seeing us in therapy, and that's exactly right.
Sure.
But where we start is often the way we've described it. Yeah.
I was really interested in this section on sex and the brain and the research that you referred to, in which you were showing the increasing rates of challenges that men who have a history of pornography addiction experience. And I'm wondering, like, what is the research showing about females who are entering long-term committed marriages or partnerships who also have a history of pornography addiction?
Same effect, because it has that same pattern connected in the brain with the body.
So like high need for dopamine release.
Yep.
Yeah. Yes. In fact, I'm thinking of a specific case where that was the case, and it was just one. What do I want to say? Trying to go from one high to the next high, and not getting with the idea of the connection and the bonding, because that's what had been conditioned by that regular porn visit. So it's amazing. We should have said that.
Yeah.
Thank you for pointing that out.
The increase in women with pornography has really been high during probably the last, 20 years,
No,
maybe?
even 10.
Maybe even more, 10, yeah. At our stage of life, the years kind of condense to when that started.
Good point.
Hi.
Hi.
I had two questions because that one actually prompted one. First one is very yes or no. The books that you recommended that you give to men and women,
Yeah.
are they faith-based? Or are they?
Yes.
Yes.
Okay.
Faith-based.
Yeah, and I'm curious about, I work with a lot of couples that are not Christian,
Right.
and to give them Christian material, they may be upset.
Oh, let's talk about
That's
that.
important.
When we get a couple, and we get many who are not faith-based, and we'll just say these are written from a Christian perspective, but we think the information in them is good, and you can deal with that to whatever degree you want to.
Or are you comfortable with that? We ask them first.
And we'd have to say I think we have no experience of anybody saying, well, that really bugged me to have that in there.
I should tell about
Yeah, you got one more.
the guy that came to me to complain about his wife. And he said, now my sister sent me here and she's a Christian and I know you guys are Christian. I don't want any of that stuff.
Any of that God talk.
Yeah. So every session he asked me about God and Christianity. Every session.
He brought it up each time.
Every time.
So but we have
yeah.
not found it to be a barrier.
Okay, good.
Yeah.
Can I ask the second question?
Go.
I don't wanna- Okay.
Yep.
Because this prompted me the question about pornography use and addiction, and you're talking a lot about the neurochemical process.
Right.
I'm wondering if you've read or seen some of the conversations that people are starting to talk about it as compulsive sexual behavior, like an obsessive compulsive tendency, less so the neurochemical aspect of it, more the obsession and the compulsive acting out. And if you have any thoughts about that.
Well, there's always been some question about whether it's right to call it an addiction. That's been true all the way from the beginning on that. We tend not to get too stuck on whether you call it an addiction or obsessive
OCD.
compulsive disorder or whatever. We're just trying to find some way to manage it, because so often the men who come are hooked on it, and that is their primary form of gratification, and they are not having that experience in the relationship. So we don't get too stuck on the label and just get focused on, okay, what are we going to do about this? And what's your goal here? Most of the time, men come to us when they got busted. The wife walked in on them at 2 a.m. when they got up out of bed, or
It often happens after the first child, or when she's breastfeeding at night and she gets up to breastfeed and he's on the computer watching.
or who knows what, or they got busted because somebody at work found all their stuff on there. So we're usually dealing with the people who are highly troubled and anxious at that moment and looking for control. And we don't get too stuck on whether it's an addiction or this. Okay? We're happy to have other people
Yeah.
who've got experience in this.
My name is Lori, and thank you so much for being here. This is just a treat. In the early 1990s or so, my husband and I frequently gave your book, The Gift of Sex, to newly married friends.
Oh, good.
And we did it in order to be able to say, we gave John and Jane the gift of sex. So thank you for that. I still have it on my shelf at work also. So.
Oh, that's great. Well, that came out in 81, so 44 years ago, and we rewrote it in 2003. And this is an interesting thing to us, when we get our royalty statements, it's still our bestseller of all of our books. We still sell more 44 years later than any of our newer books even.
Yeah. Well, again, in the Christian format, to be the title even, The Gift of Sex, was revolutionary, I think, at that time. So thank you for that. Just a question about COVID. Obviously, we know the connection between COVID and male erectile dysfunction and things can be the case. Do you agree with that? Unless it's like...
We are not knowledgeable about that. Does anybody here know about COVID and erectile
Let's
dysfunction?
excuse my husband gives. I don't know.
Okay.
Sure. But also just, again, with... that was really bad. And
And his name is Fred, right?
But also how pornography, everybody by themselves, I mean, sex trafficking, human trafficking, just since COVID, and how our world has shifted.
Sure.
I was just wondering if you've seen that in your own practices or others as well.
Yeah. One of the things thank you. What we'd have to say is we are cutting way back at our advanced age now. And so Joyce isn't seeing anyone, and except getting lots of calls and emails. And I'm not usually taking new people, so we're not as current as we once were. Now, go ahead.
Yes, we have a question from online. Any thoughts on what is needed first when couples are going through betrayal trauma, or any adjustments needed with the resources that you shared in this kind of situation?
Yes. It's very important that they seek therapy for the betrayal before they do the re-engaging in sexual therapy.
One of the things that we find when couples have been involved, where one person has been involved in an affair, often there is, once that's discovered, there is a brief honeymoon period right after it
where they have a lot of sex.
And then all of a sudden the anger comes in, and the hurt and the shame and all that. And so there's usually a spike in the frequency of their sexual activity, and they think, oh, it's all over. But then in about 6 weeks, they have to get back and really do some work. A really good resource for that is written by David Carder, Carder, called, anyone got the good name for it? It's something about... Pardon me? Torn Asunder, is that what it is? Something like that. Anyway, David Carder, Carder. He's this...
Carnes is probably the leader in the
Then about affairs or porn. That's more about porn.
That's more porn.
Yeah.
Also, the place in Arizona and Minnesota.
Yeah, but Faithful and True, written by Mark Laser, is also another good resource. Mark died a few years ago, but his wife
is carrying on
the work in Minneapolis. They see
and
couple.
often we'll refer to them first, and then they often refer to us after someone has gotten control and they've worked through the married relationship and worked through the issues.
Okay.
I have worked with couples after betrayal and after abuse, but I also work with individuals and couples after other kinds of trauma. And I've found that, a lot of couples think of good sex as just the erotic sex and have trouble conceiving of the kind of sex you have after great losses or things like that. And I was just wondering what your experience is with that.
the whole idea of the comforting kind of sex is the word that I would use, that brings people together because of the intimacy and the support and reassurance that is needed, is a very valuable thing. And I'm glad you mentioned that, because it's very much a part of what needs to happen for almost everybody somewhere along the line.
The hardest to deal with is the loss of a child.
Yeah, in
Very
fact, the statistics are pretty bad in terms of that, in terms of how many couples break up after the loss of a child, a death of a child.
And having close, warm sexual relationships seems like it would be such a comforting, wonderful thing, and yet it's so hard for them. So hard for them to do that.
Yeah, so that if you are dealing with a couple who has lost a child, talking about that kind of close physical intimacy is going to be a good ingredient in that process. John?
Yes. Two questions. One is, do you think good sex therapy can occur online?
We're too old. Melissa, we've talked to some of the younger.
Well, let's see. Can it occur?
Well, actually,
Telehealth.
I used to do a lot by telephone. That's
Well,
true.
in fact, just a little background here.
yeah.
Joyce has become the go-to therapist for Amish couples.
Yes.
And they
It's
have
very fascinating. That's the only thing I'm still doing, because they don't have telephones. So there's
they
no way.
have to get in their horse and buggy, ride into town, find a payphone booth, and then do 1 hour of sexual therapy, talking into the phone like this while
And
people are
they
driving
can't-
by.
I can't call them. So we have to try to find, some couples wouldn't even let me know when they were going to a telephone. So I just happened to listen to the telephone ring at the right time. I mean, but I get amazing results. They just are so thrilled, and they'll leave a
because
message.
these are
saying-
usually young couples who have not been able to get pregnant, often unconsummated marriages, which we haven't even talked about today.
Yeah, I always say I've consummated marriages in Norway, Russia. It's very rewarding and very fun.
So the answer is yes, we're doing it all the time.
I always think of it as using a computer, and
Yeah.
you know.
Well, I do everything online now myself, and get pretty good results with marriage counseling. But I perceive this as a very complex area.
Yes.
I have some facility with it, but not anywhere near what you guys profess. So if I get people over the affair and get them churning along with their marriage, is there someone good I could refer to them to who does this online?
We have, there is one organization called something online.
Oh,
It's got online in it. I have a whole resource list. I do that, but it's ours. We called our professional resource list for sexual, and we just have gone through it, have had an assistant go through it and get all the people who've passed away off of it and get everybody new on it. So you can call me. People call me all the time, and then I go to the resource list and find I've got people, again, in different parts of the world, all of U.S., that I can refer to.
yeah.
Yeah.
I'm glad to hear that you're staying within the boundaries.
We do have another question online.
Good.
You have 50 years of sexual therapy experience, and there have been cultural shifts along the way.
Yes.
So the question is, what is your practice when a gay, lesbian, or transgender person is referred to
Let
you?
me answer that.
Yes.
That's an interesting thing, because we have been known as the couple who does sexual therapy for couples who are married. We get very, very. Oh,
I don't think we've ever gotten the transgender.
No, not transgender.
No, she said trans.
Oh, transgender too. No, we have not had that.
We've had couples come to us where one is gay but wants to have a heterosexual relationship with their partner and wants to develop, they don't want to be able to get turned on.
They're not coming to us so that they're no longer gay. They just want to stay in their marriage because it's their belief or because of the children or because
Some
their
reason,
commitment.
and they want to be able to enjoy it.
And so
And we don't believe or pretend that we're getting them to get turned on to the opposite sex. They're only getting them turned on to their spouse and to get a positive sexual relationship with their spouse. And that's the only thing. The only one we had an
this is
interesting, fun one where,
I know it was fun, but
no, but humorous kind of. The woman they had come, and all of a sudden the woman says, "I'm sorry, I have to stop this process."
and here's the way that one went. They had come and they had come together, but she particularly had come knowing that sexual therapy wouldn't work because she wanted to be able to say sexual therapy didn't work. And now we were taking them through the exercises and it was working. And
So
she
she
had
stopped
come,
because it was working to say, "I really have a female I want to be with, and I didn't think this would work, and it would just blow up, and now it's working, and I
so
don't want to
I
be
don't
here."
want to come back.
So, but those are our limited experiences.
Well, listen, you guys have been very attentive and responsive and involved. Thank you for listening to us
Yes.
ramble about all this stuff that we've been doing.
I said,